help. I think it's more comfortable to present with the OR suit.
Well,
I think it's more.
In the US at the moment, none of the doctors are wearing normal clothes. We're just wearing the scrubs for everything.
That's more comfortable actually than the tie and these things. Okay, Mohab, when you are ready to start, you can just let us know.
We are ready, Dr. Ayman. We have 70 attendee till now. I think we can start now.
We have reached 9.
73. Yeah, we reached 9. It's 9-1.
Great. Okay. Okay, Dr. Heba, you have the mic.
Okay, thank you. Can you hear me? Can you hear my voice?
Yes.
Then good evening, everyone, wherever you are. It's 9 p.m. Cairo time and 3 p.m. New York time. This today will be the 3rd International Memorial Institute Kids Eye Center webinar. We are interested and so excited for tonight's webinar because we expect to have many discussions, debates, updates, and everything about the Ectopia Lentis. We are so excited for tonight's meeting because we have as a guest speaker 2 of the most talented pediatric cataract surgeons all over the world. We have Dr. Ken from New York, Professor Dr. Ken Eshel. We have Professor Dr. Nihal Ishaqanqiri from Alexandria University, Egypt. We have Dr. Mahmoud Yusri, our clinical geneticist in our newly established clinical genetic department. I have also on the board Dr. Ayman Ghanimi, my dear colleague, and myself, Heba Mtwali from the Memorial Institute Kids Eye Center. You can watch this meeting via the Zoom platform or via the Facebook live streaming, but we encourage all of you to watch this meeting through the Zoom platform so you can engage with us with your questions, interactions, and comments for all of us to have valuable and discussions and fruitful discussions and for all of you to enrich our meeting today. And we kindly requesting from all of you to leave your questions in the Q&A box and not in the chat box for all of us, so to follow you better and so we can answer you live or by texting. I'd like, before going ahead and start my meeting today, I'd like to thank RM Organizing Company because they paid a lot of effort with all of us from the first beginning of our journey in the Memorial Institute Kids Eye Center scientific activities, and they helped us build our virtual community from inside and outside Egypt, and actually they have a great share in our success of the meetings. And we have 3 sections for tonight's meeting. We have the first section about the pre-operative assessment of the Ectopia Lentis cases, and we have the second section about the clinical geneticist approach, which may be different from the ophthalmologist approach, and we can see how his approach would be valuable for ophthalmologists. And we have the last section, which is the surgical techniques of Ectopia Lentis. Let me start and presenting our first international first guest and our international speaker today, Professor Dr. Kanwal Ken Eshel. He has MD, FAAP, and FRC Opht. And he was born in Nairobi, Kenya, and grew up in England. He is a director of the World Society of Pediatric Ophthalmology and Strabismus, and he is a professor of ophthalmology and the division chief of Pediatric Ophthalmology and Strabismus in University of Pittsburgh Medical School of Medicine. And the Children's Hospital of Pittsburgh. He's a medical director of the Digital Health of University of Pittsburgh School of Medicine, and he is a vice chair quality and of the UPMCI Center. He has ideas in building up all the ophthalmology community and gathering all the ophthalmologists in one big society, which is the World Society of Pediatric Ophthalmology and Strabismus. Thanks, Dr. Ken, for accepting the invitation, and thanks for having you tonight. Our second guest today, Professor Dr. Nihal Shaqanqiri. She is a professor of ophthalmology in Alexandria University. Dr. Nihal also gives all the persons around here a great positive energy of teaching and making charity acts for all the kids and even the doctors around here. She is interested in teaching all the young generation, and she is interested in paying all her time, effort, and any expertise she had developed and raised in the ophthalmology, and especially in the pediatric cataract surgeries, to give it all in for the charity work only. Her a charity project for the pediatric cataract surgery in Egypt changed a lot of all of us and in all the kids in Egypt all over the country. We always learn from her a lot, and learn from her passion, from her charity, from her kindness, from her giving, from her positive energy, and from everything. Thanks for having you today, Dr. Nihal. And I'm so pleased to announce that Dr. Nihal will help us in our project, which is the Memorial Institute Kids Eye Hospital. Thanks, Dr. Nihal, for having you today. And let me present now my dear colleague, Dr. Ayman Al-Ghanimi. Dr. Ayman Al-Ghanimi is a board member of the MIC. He is a consultant of pediatric ophthalmology and strabismus. He joined Mayor since 2015. He is a consultant of ophthalmology in Maghrabi Eye Hospital since 2003, and he is a fellow of the Bascom Palmer Eye Institute of Miami, USA. Dr. Ayman, good evening. Please unmute yourself, Dr. Ayman.
Thank you, Dr. Heba, very much. Thanks for this nice introduction. And again, I'd like to welcome our special guest speakers. And just a quick tour on the Memorial Institute Kids Eye Center, because we're proud of this center. It's a new building for our pediatric unit. The Memorial Institute Kids Center has 6 general clinics and subspecialty pediatric ophthalmology clinics, strabismus, pediatric retina, pediatric cataract, glaucoma, oculoplasty, and pediatric ocular genetics. Interesting, and we're proud of having this. This is a pediatric cataract clinic in our center. Pediatric glaucoma is a clinic, and we have the electrophysiology units, and that's we are proud to have this child-friendly inpatient department in our center, and state-of-the-art operating rooms. And I'm very glad to that we have with us Dr. Mahmoud Yusri. Dr. Mahmoud Yusri, he is a researcher of clinical genetics and clinical genetics department in the National Research Center. He's a consultant in pediatric and neurogenetics, and he actually the founder of the Ocular Genetic Unit in the Memorial Institute of Ophthalmic Research. So we are very proud to have him, that we started this Ocular Genetics Day, the cooperation between ophthalmologists and the genetic point of view in our center. So we are very glad to have him. Welcome, Dr. Mahmoud.
Thank you, Dr. Ayman, for the nice introduction.
Welcome, Dr. Mahmoud. And finally, I would like to welcome my colleague, Dr. Heba, who is a board member of the MIC, consultant on pediatric ophthalmology in Mayor since 2003. She has MD, FR, and she had a fellowship in Maghrabi. She joined Mayor in 2012 and started the pediatric ophthalmology unit in 2013. I like the picture. Welcome, Dr. Heba, and the mic is yours. You can unmute yourself, and let's start our webinar.
Okay. Now,
let's start.
So now let's start our meeting and start by the first talk. Our first talk today will be by Dr. Ayman Al-Ghanimi, and will be about the pre-operative assessment of Ectopia Lentis case. And I hand the platform to Dr. Ayman.
Thank you. Let me start sharing. Sorry. Okay, so the first thing we will start speaking with is the the pre-operative assessment, just very, very few points in the pre-operative assessment. Let me see. Yes. Okay. Just I think, can you see my slides now?
No.
Okay.
Yeah.
Let me make sure that I think it should be there now.
Yes.
Okay. I think the slide now. Okay. Yes, just tips about the pre-operative assessment of ectopia lentis. Ectopia lentis is simply displacement and malposition of crystalline lens of the eye. It has first reported case back to the 1700s. And the first case of congenital lens dislocation has been reported in 1856. It's basically can be caused by trauma, ocular disease, or it can be an association with systemic disease, whether congenital disorder or that has spontaneous that appears later in life. So, and this is the part that actually are concentrating in this webinar, which could have a genetic background or just an isolated subluxation, or can be associated with a syndrome. The systemic association are a lot. The point is that we all know that Marfan is one of the most common association of these ectopia lentis, but I will not talk about the systemic manifestation, which we all read in books, and Dr. Mahmoud will speak about it. But I just want to make a hint that many times we have very atypical cases, and not just the very classic picture that we have in books. So we have to suspect the important syndromes in every case with subluxation. The homocystinuria is also one cause, and we have a long list of the subluxation that we need to be aware of, and I'll leave this for Dr. Mahmoud. And again, every case of subluxation should have a systemic and genetic evaluation in addition to the ocular evaluation. Usually the patient with ectopia lentis present with decreased vision, unusual change of refraction. So we have sometimes the presentation is just the refraction is changing unusual, the cylinder is increasing without an explanation, or the myopia is increasing, or maybe just seeing accidental discovery while we are doing our normal examination. It could be lateral, could be bilateral, according to the associations. I will, in very short, speak about some tips. The many cases of Marfan has a typical presentation called the Marfanoid feature. So if you are in doubt of having this Marfan syndrome, you have to order the cardiological assessment. That's extremely important because of the associated life-threatening actually conditions in the heart, and it has risk in the general anesthesia. And also the same with the case of homocystinuria. If there any suspicion of case of homocystinuria, we still have to order some labs because it has a risk of thrombotic insults under general anesthesia. And again, some short tips about ocular examination. When you have a high cylinder, you have to suspect. And when you are doing refraction, it's very important not to rely on the autorefractometer. You have to do the retinoscopy, because usually the autorefractometer gives false measurements in such cases with subluxation. So we really rely on the retinoscopy. Even in the autoref, it can show a high hypermetropia because even the patient is myopic, because simply it can take readings from the aphakic side outside the subluxated lens. So also, we should never forget to examine thoroughly the peripheral retina, because in many times we have a common association with peripheral retinal degenerations, peripheral retinal lattice, especially in cases of Marfan. One, the patient undilated to assess exactly the level of the relation of the edge of the lens with the pupil in the normal condition, but then we have to check the dilatation. Because some cases of Marfan has poor dilatation, they have sometimes poor dilated papilli, so we be prepared in the surgery that we may face a case of poorly dilated pupil in the surgery. I don't want to spend much time in this presentation, and about the surgical decision, we will leave it to the second part of this webinar. And now I'm introducing Dr. Ken to speak with us of some of the interesting tips, other tips in the pre-operative assessment in cases of ectopia lentis. Dr. Ken.
Thank you. Thank you very much for inviting me. It's a pleasure to be here with you guys. So let's talk a little bit about the pre-operative assessment. So I think these are my disclosures, by the way. None of them are relevant to this actual presentation. As far as the clinical assessment is concerned, I think it's important to remember that we, in this day and age, have so many gadgets, right? Ophthalmologists are known for their gadgets, but the most fundamental part of your evaluation is observation. If you can, when you see a patient, concentrate on the observation of what you see and not what you think you should see, you will always make the correct diagnosis. This is courtesy of my previous colleague at Great Ormond Street, Isabel Russell-Eggett. And I'm going to slow that movement down. And you see this fluttering of the iris. Now, in somebody who is phakic, there is only one thing that can cause this iridodenesis, and that is either a lack of zonules because of trauma or a subluxated lens. There is nothing else that can cause this. So I'm going to show this again in real time. It is the flutter that you're looking for. It's a simple observation, but it's a very important observation. Sometimes you can see phacodenesis. In other words, the zonules are so weak or so disrupted that the lens will move. And it's very important to make a note of iridodenesis or phacodenesis. Why? Because when you dilate somebody who has iridodenesis, there is a very small risk, but a very real risk, that the lens will dislocate into the front of the eye, and you then have an emergency in terms of either removing the lens or ballotting the lens back into the back of the, behind the iris. So this is all stuff to make life easier for you. I don't really want to go into my colleague's talk, but I do want to point out that I'm old enough to remember when we used to see a dislocated lens and we used to say, well, the patient is you know, reasonably tall or is not short, hasn't got stubby fingers, which is what you see in Weill-Marchesani syndrome. So it must be Marfan syndrome. And we used to find these fibrillin 1 mutation negative patients. And I was lucky enough to be the part of the group that first reported ADAM TSL4 mutations in FBN1 mutation negative Ectopia Lentis patients. These patients would only have Ectopia Lentis. Everything else would be completely healthy. Now, the ADAM TSL family, it's really interesting, can be seen to cause other conditions, rare conditions like Ectopia Lentis at Papilli, and can also be caused, ADAM's TS10, as recessive disorders or recessive cause of Weill-Marchesani syndrome. So this protein is important in zonules. So often in these cases, you get spherophakia or microspherophakia. One thing I will say is when you look at the metabolic disorders, hyperlysinemia, sulfocytinuria or sulfite oxidase deficiency, and molybdenum cofactor deficiency, these children are not well. In molybdenum cofactor deficiency, the child is often in status epilepticus, and so you're not going to see this in a well child who walks into your clinic. So be aware of that. So these are the pictures of Ectopia Lentis, and again, my colleague has very nicely described what happens. I want you to note that the zonules are intact. I want to share with you a very important example. This was a 5-month-old male presented in my clinic for suspicion of craniosynostosis. He didn't have craniosynostosis as it happened, but there was a suspicion. And when I saw him at 3-month follow-up, this is at 8 months of life, he clearly had iridodenesis. I explained to parents the risk of dislocation of a lens. They allowed me to dilate him. I want you to note that his refraction on his initial exam wasn't terrible. This is the best picture we could get, and you can see that the lens is dislocated. This is the slit lamp drawing. Now, in this child, his cornea was flat. The Australian registry paper from about 15 years ago showed that if you have dislocated lenses and a flat cornea, the cause was a Fibrinium gene mutation, whether a type of Marfan syndrome, in other words, Marfan syndrome. So clinically, I am convinced that this child has Marfan syndrome, and when you do a pedigree, you begin to notice that there's a history of vertebral artery dissection, there's a history of unusual skeletal malformations, and so already there's a suspicion that this could be an autosomal dominant condition. He had cardiology done, and he had a mildly dilated aortic root. He had a tricuspid valve regurgitation, and so he had Fibrinium 1 sequencing done. Now the sequencing came back as negative, and what I want to say to you is that just because your molecular testing doesn't prove your clinical diagnosis, it does not mean that your clinical diagnosis is wrong. We also have to understand that the way the testing is done nowadays, this is next generation sequencing. In other words, it's like speed reading a book. When you speed read a book, if a paragraph is completely missing, you can still make sense of the whole book. So I insisted that this was Marfan syndrome, and then they went back and did this technique called MLPA. Doesn't matter what it is, but if you like, it looks for deletions and duplications within the gene, and we found a deletion. In other words, a paragraph was missing. When they did the speed reading, the chapter made sense. So they said there was no problem. But when they went back and read again in a different way, they found that there was a deletion. So I'm going to stop there and say your preoperative evaluation is extremely dependent on good, solid observation followed by clinical diagnosis, and nothing replaces that. Thank you.
Okay, Dr. Mahmoud. Thank you, Dr. Khan. That's very interesting presentation. And very, very nice tips. Dr. Mahmoud, you can start sharing your presentation, and then we'll have discussion. I'm eager to know the opinion, the comments from Dr. Nahan and from the audience.
Okay, can you hear me
Mahmoud.
well? Yes. Can you hear me well?
Yeah, please.
So I will start talking about Ectopia Lentis and the genetic background. It's dislocation of the lens by partial or complete disruption of the zonular fibers. It has prevalence about 6 per 100,000 population. It can be due to traumatic or genetic cause. Many genetic causes of Ectopia Lentis have been identified, either a part of genetic syndrome or isolated disorder. The isolated form may be either autosomal recessive or autosomal dominant. Here's a chart, a simplified chart, either hereditary Ectopia Lentis, we can see it's either isolated, and the isolated form may be recessive or dominant form. We have syndromic, either Marfan, homocystinuria, or Wilmer-Cassani syndrome. There are other syndromes that may be associated with Ectopia Lentis. What is the importance of the clinical diagnosis and genetic diagnosis of Ectopia Lentis? It's crucial to differentiate between the syndromic and isolated forms for proper surveillance, management, and genetic counseling. As Dr. Ken said, that he suspected that the case is Marfan syndrome, so he insisted in doing the genetic test, and this diagnosed the child as a Marfan syndrome, so we can anticipate the cardiovascular problems in this case. Genes involved in Ectopia Lentis, as Dr. Ken said, the Fibrinium gene can present either like in complete Marfan syndrome or dominant Ectopia Lentis or dominant form of the Wilmer-Cazzani syndrome. The ADMTS-L4 can be presented either by isolated Ectopia Lentis type 2 or Ectopia Lentis Papilli or Ectopia Lentis and craniosynostosis. We have the homocystinuria and ADMTS 10 and 17 causing Wilmer-Cazzani syndrome type 1 and 4. We have the collagen 18A1 can present with Knoblich syndrome, and the LTB-P2, latent TGF-beta binding protein 2, and it can present with Wilmer-Cazzani syndrome type 3 or microspherophakia and or megalocornea with Ectopia Lentis and with or without secondary glaucoma. And VCX2 can cause high myopia, Ectopia Lentis, and corneal road dystrophy. Other genes involved in Ectopia Lentis, like as you said before, the sulfocystinuria SOX gene and POCRN causing focal dermal hypoplasia. It's X-linked recessive, AAS hyperlysemia, ASPH causing thrombosis syndrome, BCOR X-linked and cause microphthalmia syndromic, oculofaciocardiodental syndrome, and P3H2, which causes autosomal recessive myopia, myopia with cataract and vitreoretinal degenerations. The Marfan syndrome is autosomal dominant connective tissue. The gene causing Marfan syndrome is Fibrinium gene. It's characterized by musculoskeletal affection, cardiovascular, and ocular abnormalities. The Ectopia Lentis in Marfan syndrome is around 30 to 72% of cases, and there is a scoring system for Marfan syndrome according to the clinical presentation of the child and is associated with Ectopia Lentis or not, and you can find the site for Marfan syndrome calculation for the risk factors. The clinical picture of Marfan syndrome, as you said, is characterized by long thumb crossing the border of the hand, Marfanoid habitus, tall limbs, arachnodactyly, and there's scoliosis and heart problems. It can cause disproportionate tall stature. The arm span is more than the height. The ratio is above 1.05. There is eye anomalies, including Ectopia Lentis, cardiovascular defects, including aortic root dilatation, aortic dissection, and ascending aortic aneurysm. Hence, it's important to diagnose the Marfan syndrome for anticipating the cardiovascular defects. The skeletal affection, scoliosis, joint hypermobility, arachnodactyly, and pes planus. The fibrinogen gene is one of the major constitutive element of extracellular microfibers and is widely spread in both elastic and non-elastic connective tissue. The fibrinogen gene is a large one consisting of 65 coding exons around 200 kilobase pairs and is located on chromosome 15. It encodes a member of fibrinogen family proteins. The encoded pre-pro protein is theoretically processed to generate two proteins, including the extracellular matrix fibrinogen 1 and protein hormone asparagine. Fibrinogen is an extracellular matrix glycoprotein that serves as a structural component of calcium-binding microfibers. These microfibers provide force-bearing structure support in elastic and non-elastic connective tissue throughout the body. Fibrinogen gene can cause other syndromes like acromicrotic dysplasia, Ectopia Lentis familia, which is autosomal dominant, gediophasic dysplasia type 2, Marfan dystrophy, Marfan syndrome, Steve-6 syndrome, and Wilmer-Cazzani syndrome type 2. The fibrinogen experience a variety of phenotypes produced by mutation in different parts of the collagen genes, and in other genes suggest that related Ectopia Lentis could be caused by mutation in the fibrinogen of different nature or a different site than those which cause the full-blown picture of Marfan syndrome. Homocystinuria is autosomal recessive metabolic disorder of sulfur metabolism due to homozygous or compound heterozygous mutation in the cystathionine beta synthase. It has the clinical feature of myopia. Ectopia Lentis is present in 90% of cases. It's bilateral and influenza. Mental retardation, skeletal anomalies resembling Marfan syndrome. They have fair colors of skin and hair. This table shows some clinical differentiation between Marfan and homocystinuria. Marfan is autosomal dominant, homocystinuria is recessive. In Marfan, there's upward lens dislocation. In homocystinuria, there is downward lens dislocation. In Marfan, there is aortic incompetence. In homocystinuria, there is the heart is rarely affected. In Marfan syndrome, there is normal intellectual development, but in homocystinuria, there is mental retardation. The complications of Marfan syndrome are pes planus, hernia, and scoliosis, but in homocystinuria, we have recurrent thromboembolism and osteoporosis. We can diagnose homocystinuria by homocysteine in urine and methionine, and measuring the cystathionine beta synthase activity. Ectopia lentis Papilli, it is autosomal recessive disorder. This displacement of the lens and the pupils may be associated with other ocular anomalies without systemic manifestations. The other ocular anomalies like cataract, megalocornea, glaucoma, and retinal detachment. It's usually bilateral. Lens and pupils are displaced in the opposite directions. The ADMTS4L4 is a secreted glycoprotein that is widely distributed in the human eye, enhanced Fibrinium Gene deposition in the presence of the ADMTS-L4 and co-localization of the ADMTS-L4 with Fibrinium in the extracellular matrix membrane of culture fibroblasts suggests that a protein role of ADMTS-4 is in the formation of and maintenance of the zonules. It is one of the family of zinc-dependent proteases that are associated with connective tissue organization, coagulation, and angiogenesis and cell migration. Collagen 18-1 is causes Noblex syndrome type 1, which is recessive. There is attachment and occipital encephalocele. Ectopia Lentis and other anomalies are associated. This gene provides instruction for making the protein that is used to assemble type 18 collagen that strengthens and supports connective tissue. Wilmer-Casain syndrome is a rare genetic disorder characterized by short stature, short hands and fingers with stiff joints. We have broad head, brachycephaly, ocular abnormalities, spherophakia, and Ectopia Lentis. It is either autosomal dominant or autosomal recessive inheritance according to genes involved. There is hard defect sometimes, and they have lens subluxation that may proceed to lens dislocation. There are 4 types of Wilmer-Casain syndrome. Type 1, which is caused by ADMTS gene, the 10 gene. Type 2, which is caused by Fibrinium gene. And this is the only one that is autosomal dominant. Type 3 by LTBB2 and type 4 by ADMTS17 gene. This figure shows the interaction with Fibrinium gene, showing domain Fibrinium and relevant ADMTS proteins. In the bottom, the Fibrinium domain structure are associated by the sites for the indicated molecules. The location of Fibrinium mutations identified in Wilmer-Casain syndrome and stiff skin syndrome are shown below in Fibrinium domain structures. Also, this representation of convergence of emerging of human and animal phylogenetics that point the role of ADMTS 10, 17, and L2 in the function of microfibrils via interaction with Fibrinium 1. There are other syndromes that are associated with Ectopia Lentis, but no candidate genes like Nest syndrome, like dysplasia with Ectopia Lentis, called Bruton, and blepharoptosis, myopia, and Ectopia Lentis. I like to briefly discuss with my colleagues who doesn't know what is recessive and dominant disorders. In the recessive disorders, you have one copy of the allele which is mutated. So in the carrier state. So if you have both copies affected or mutated, then you present the disease. If one copy is only mutated, you are carrier. If you don't have any mutated copy, then you are not carrier affected. But this is, we can see that the father is carrier and mother carrier. The one we have, the child who have 2 copies affected is affected, and 1 copy if mutated, you are carrier, and you have not mutated copies, you have the wild type, you are not affected. This family shows a presentation of recessive disorder. You can see that father and mother are related, and they are not affected, healthy, and they have 2 affected girls. In the dominant inheritance, you have 1 mutated copy of the gene. it's either inherited from the parent or it's either de novo mutation that happens without any inheritance from the parents. Here we can see on the left side, the father is affected. He has 50% recurrence risk in each subsequent sibling or pregnancy. And in the other side, the father and the mother are not affected, but there's a de novo mutation in one of their children. X-linked recessive is a caused by mutation on the X chromosome. It only affects males. If in the females you have two who have two chromosomes, a mutation would have to occur in both copies so that it can be affected. Characteristic of X-linked inheritance is no male-to-male transmission. You can see that this is the father affected, and he passes his affected X chromosome to his girls, but he doesn't pass it to his sons. On the other hand, with the mother is carrier for the mutation, she passes to her affected sons, and all her girls are not affected, but she can give birth to a carrier daughter. And you can see from the family pedigree for X-linked recessive, it has like the horse first or night movement in the chest. You can see only males are affected. And thank you.
Thanks, Dr. Mahmoud, for this, for me, very difficult lecture. But I want, it's all about a big experience in the genetics. And we want to ask a question which is helps the clinical uses of the ophthalmologists. And I want to start with, again, back to Dr. Nihal, and then I will be back to you with questions for clinical application for the ophthalmologists in their clinic when they deal with Ectopia Lentis case. For Dr. Nihal, good evening, Dr. Nihal. My question is for you.
I think she's not with us. She has a technical.
She's not here. So
I missed to ask Dr. Mahmoud about this. Yes, this is a very interesting question that you have raised, Dr. Habib. That I want Dr. Mahmoud to tell us when I am as an ophthalmologist, when I see a case of subluxated lens, should I refer it for genetic counseling every case or some cases? In short, what do you think that convinced me that I should refer the patient for genetic counseling?
Okay, if it is not traumatic and it is bilateral, for sure it is genetic. So
and what if it is unilateral? If it was unilateral?
If it is not unilateral, if it is bilateral,
yes.
Okay, and for sure it is genetic, I think. And if there is a positive family history, for sure it is genetic. And if it is not traumatic, you can ask if there is a trauma or no. If there is no trauma, and it is bilateral, I think it is genetic.
So you do not find that you do not convinced that some of the Ectopia Lentis cases are isolated cases?
There are some cases isolated. I've seen two families with isolated Ectopia Lentis. You should screen the child for any other dysmorphology. If he is short stature and with the stiff joint, you can think about skeletal dysplasia syndromes or Wilmer-Cassani syndrome. If he has a tall stature and the arm span is more than the height, then he has Marfanoid habitus. You can think about homocystinuria and you can think about Marfan Syndrome. So you should clinically screen the child before referring to genetic counselor. Then you can refer him to the genetic counselor for completing the evaluation, then doing the genetic tests.
So thank you, Dr. Mahmoud. My question now is for Dr. Ken. Dr. Ken, if I had a case in my clinic and I find that it is aphakic and she had a history of dislocated or subluxated cataract lens and now came for me for management, for correction of the pediatric aphakia. Does it differ for you, for example, to know was it microspherophakia case or just Ectopia Lentis case, and how far you see the difference between the two entities, and how can genetics help you to differentiate between the two entities?
So, you know, there are a couple of things that I'd just like to say before I answer your question. Dr. Ayman said convince me that I should do genetics. So my only question to Dr. Ayman is, Dr. Ayman, if you have a Mercedes car, do you need convincing that you take it to a Mercedes specialist?
No.
Or do you take it to any mechanic?
That's very convincing.
No, you see, the thing is that we as ophthalmologists have to change our mindset.
Yes.
Our mindset is that we look after the eye, and that's true, we do. But the eye truly is the window to the soul. And I tomorrow I'm doing a genetics webinar in India, where I'm going to show 5 cases where the life of a child has either been saved or changed permanently by a diagnosis made by an ophthalmologist. Yesterday, to give you an example, I saw a 9-year-old girl who has got hypermobility syndrome, and she's been seen by 7 ophthalmologists, all of whom have said everything is normal. But what they missed was that the child stood in front of me and said, look what I can do to my skin. And when she picked her skin up, it came away this far. I then look at her neck. She's 9 years old, and she has the plucked chicken skin sign of pseudoxanthoma elasticum. You look at her fundus, and she has an angioid streak that's coming close to the macula. See, the question really is how inadequate do we want to be as doctors in 2020? We can continue to be inadequate doctors and very good ophthalmologists, but I want to be an adequate doctor and an excellent ophthalmologist. And we all have to make that personal choice. Now, going back to your question, the issue of what the connective tissue disorder is will determine for me what is the safest thing to do for that child. If the child is 14, and I put it to you very simply, if you're in a region of the world where genetic testing is not considered to be important or is very expensive, then the question that you should be asking us is not what is the genetics, but what is the simplest thing that we can do to change the child's life. I'll give you an example. If a child is born with aniridia and you can't test for genetics, you do a renal ultrasound scan so that the child does not have Wilms tumor. If the child is born before the year of 1 has retinal dystrophy, you do a renal ultrasound scan to detect that they're not got nephronothiasis and are not going to go into renal failure. So if you have a child who comes to you with a subluxated lens or is aphakic because of a subluxated lens, you do an ultrasound of the heart. Because if the child dies because of aortic root dilation that was missed, or nobody put them on a cheap drug called a beta blocker, then I put it to you, we are useless doctors and great eye doctors. And I don't want to be a useless doctor. So for me, the question will be, if there's a connective tissue disorder, don't think about sewing anything into the eye because the wall will melt and you will run into a problem. If the child had, and you talk about isolated, see, almost all the isolated Ectopia Lentis cases are due to the Adam TS family mutations. Adam's TSL4 being the main one. And they have a connective tissue disorder. So for me, even if it's a metabolic disorder like homocystinuria, I still would prefer to correct them conservatively or with an iris fixated lens until they're much older, and then they can make the decision as to whether they want to take a risk with the eye. So I apologize if I sound like I'm a priest trying to preach. I'm not, but we should be good doctors and excellent ophthalmologists.
Right, Yori, we agree. We all agree about it, but
That's
I think
that's a perfect comment. That's the point that I raised, that why it's in many places it's still not yet the genetic is not involved, integrated in ophthalmology, in ophthalmology, especially the pediatric ophthalmology practice. And that's why we are proud to start this huge communication with Dr. Mahmoud and us in the same place, both of us with the genetic lab in the same place. So this cooperation, and this just sending the patient for genetic counseling, but I mean, doing the proper thing all the time. Thank you, Dr. Ken, for this clear comment.
Thank you, Dr. Ken. We are all convinced about the words. No hard feelings. Dr. Nihal, do you have any comments or additional steps you want to add to the preoperative assessment and preparation of the patient to Dr. Ayman just said in his presentation? Please unmute yourself, Dr. Nihal.
Muted. Can you hear me? Well, actually, I agree with Dr. Ken 100%. It's not a matter of being priest. This is extremely important. You should not be just a surgeon. This is the least thing and the easiest thing to acquire. But you have to be first a good clinician, because it's not a matter of doing surgery and the eye is perfect and then there is a major thing and a major harm. You're gonna cause a major harm to the child. So first, it is better, and it's more difficult to be a good clinician, to put all the parts of the puzzles together, not only looking to the eye, but looking to the body as a whole. Maybe we are deficient in the genetic counseling and the part of the genetics, but this is not an excuse, as he said. And we have to make a sort of cooperation, if we are not a good clinician, at least with a pediatrician, to screen perfectly for these children and know the etiology. We had a case of microspherophakia that was 1 month ago, and she was not diagnosed. She came just as a primary congenital glaucoma. It's not primary congenital glaucoma, it is microspherophakia. And then after investigating her, she had a pulmonary stenosis that was left for more than 5 years unnoticed. And then she went for pulmonary artery plasty, she did the valve, and then she came, and then finally we saved her vision. If you go directly to the surgery, we would put her into risk of death. So thank you, Dr. Ken. It was really well said.
Okay, Dr. Ayman, final words about, do you want to add anything to the preoperative evaluation after Dr. Ken and Dr. Mahmoud?
I just want to summarize. I'm happy that we could raise all this awareness about the importance of this preoperative assessment and this. And I always teach the residents that when any patient comes to your clinic, you have stepwise priorities. Number 1, saving the patient life. Number 2, saving the patient vision. And so every patient, I have to exclude anything that could alter the life. That and I would like to add also that how many times I've seen a case of aniridia that just has been followed, that nothing can be done, and then keeping following, and nobody told her that the patient that they should go for abdominal ultrasound or even go for genetic analysis. So thanks. I'm happy that we raised this issue that clear. Thank you.
I just want to say one thing. Many of you know Jack Kansky, who unfortunately passed away at the beginning of last year. He was my mentor. And Jack used to say to me, your eyes are no good to you if you're dead.
Yeah, true.
That has stayed with me forever.
Okay, and now thanks for you all for the preoperative evaluation section. And now we are to start the third section in our webinar, and we will go ahead and start the surgical techniques section. We will start by Dr. Ayman Al-Ghanimi talk, anterior approach lensectomy and iris fixated IOLs. Dr. Ayman Al-Ghanimi, the platform is.
Thank you. So it's time for surgery. Now, after checking and saving lives, we start to now do the surgery. So my first question that, okay, when you do lensectomy to a patient, before presenting some surgical videos and from us and from our guest speakers, let me ask the audience, when you remove the lens, let's show us the poll, please, for the, Mr. Mohan, please show us the poll for the audience. And let's ask the audience, what is your preference? When you do lensectomy, what do you do next? Would you primarily insert an iris fixated IOL? Would you primarily insert a scleral fixation or a mani, using any technique or whatever the technique you like? primarily, or you will just finish the surgery and then implant an IOL in a second step, or just leave the patient a fake and prescribe multifocal or bifocal. So please, for the audience, you have 10 seconds to put your opinion before start sharing some surgical videos. Mr. Mohammed, please, would you please show us the results? Interestingly, wow, there's a lot of debate, but we can interestingly see that 37% choose that we'll finish the surgery and implant later on as a second step. The next choice was in 25% that primary insert iris fixated IOL. That's interesting. So let's start our first surgical. This is a surgical video, a very short 4 and something minutes about the anterior approach lensectomy with iris fixated IOL. And this, there are a lot of tips on this. You can see this patient with this subluxation, significant. Filling the anterior chamber with the heel is important to try to flatten the lens as you can to facilitate the anterior capsular access as much as we can. Here we can see how the anterior capsule is quite not easy picked up, as you can see here. So it takes us some time and some difficulty to start opening gently. And of course, I had to know that we are trying to do as gentle as we can to keep these weak zonules from getting away from us. So we just make an opening this of the anterior capsule and then introducing the microaccess forceps. Again, we have to be quite careful while doing the anterior capsular access. And that's very important that we try to not, some people are saying, why don't we go on with the cutter and just eat the whole lens? No, we have to make sure not any part of the cortical matter or lens matter to fall down. So we have to be careful capsular access and then start irrigating, aspirating the whole lens matter before eating the entire capsule. Here I'm using the irrigation aspiration, the manual technique, and you have to start removing the lens matter from the part that is toward where the lens is there. Like this, the lens is towards the 12 o'clock. So I start doing this because if you start removing the lens matter from the subluxated side, the whole lens may shrink, and then it will be more difficult for you to get the lens matter on 12 o'clock. So first, let's try to finish the lens matter from the shifted part of the lens, and then you go for the other parts until you finish all the lens matter of the subluxated lens. And then here I'm introducing heel in the bag, but trying to spread the bag as much as we can to, again, to facilitate cutting, avoid, again, the shrinkage of the lens capsule, which can make the lensectomy, the excision of the main part of the capsule is difficult. So spreading the lens capsule, the whole lens capsule, and then start eating with the cutter the different parts of the lens, the capsule, as you can see here. And then we may need to do some anterior vitrectomy to facilitate, because in this patient, I plan to primarily implant iris fixated IOL. So sometimes we need to have some anterior vitrectomy to facilitate the induced meiosis that we will insert. In this case, after finishing the lensectomy, inject the microcole to constrict the pupil, and actually it constricts quite easy. Some people say after dilatation, how can we close it? It takes like very few minutes to get constricted. Then enlarging the wound for the insertion of the phakic IOL, as you can see here, and you can see the pupil has been constricted now for the insertion. And after it, measuring the exact amount needed with a caliper, and then getting the IOL. Inserting the IOL in the AC with the proper viscoelastic, and then putting it in horizontal plan. Here is introducing the wound for the inclination, holding the lens, and then putting the inclination in the haptic. And then the other side, inclivating the other side, and keep it horizontal, as you know. And finally, doing a peripheroidectomy using the vitrectomy probe, doing a peripheroidectomy, and finally moving the viscoelastic and taking the sutures. I would like to thank actually the one who taught me these cases, Dr. Farah Absami, the consultant of cornea and refractive at the Memorial Institute with us, who helped me in the first cases where I started this. Thank you very much. I'm eager to learn from the experts about their comments about the surgical technique. I'm sure that I'll get a lot of benefit from their comments.
Thank you, Dr. Ayman.
Now, Dr. please start your presentation about your choice of Yemeni technique, I think, right?
Yes.
Thank you.
Well, I know there are many controversies about the use of Yemeni technique or the scleral fixation technique in kids in correction of the pediatric aphakia in general. I know there are two schools, or maybe most of the pediatric ophthalmologists prefer the iris glow lens over the scleral fixated lens in the correction of the pediatric aphakia, but Yemeni technique still has some important indications where you unavoidably need to correct the pediatric aphakia, while, for example, you have a severely damaged iris, so you cannot trust the iris support to put an iris glow IOL. And even with any patient have previously dislocated artisan many times and have and the patient has many iris atrophy parts, and you do not trust anymore the iris for the support of the iris glow lens. And even if you have a hyperactive or mentally retarded patient and you need to correct his aphakia, you need a more stable way of implantation of the IOL for this patient. I know that this technique better to be avoided in all cases with high incidence of RD like Marfan, for example, or any patient with proved to have a connective tissue disease, as Dr. Ken just said. And I know this technique has a very steep curve, but to my mind, and I started using this technique after seeing the good, stable, and long-term stability and very few complications of the results of this technique by our anterior segment surgeon, Dr. Rasha Musa. And so I started using this technique in correction of the pediatric aphakia after here. And I think one of the very important clause to use this technique and to have a faster curve of learning is to learn this technique from a good mentor that helps you avoid all the mistakes he had done in his experience with the technique, and helps you to start from the point he ends up to. And so today I will tell you some of my tips and tricks in Yemeni techniques in pediatric age group. Although the technique has these advantages, but the technique has other advantages. I'm talking now about the Yemeni technique and not the suture, doing the scleral fixation using sutures. In Yemeni technique, there is no suture-related problems and there is no flap-related problems. And the lens implanted by the Yemeni technique is more stable than other technique, than the iris glow lens, and even less susceptible to traumatic subluxation. You know, if you want to extract a haptic that had previously implanted intrasclerally by Yemeni technique, it's very difficult to extract this haptic. It's not difficult in every time you want to extract or even to make IOL exchange. And so this technique gives a more stable results of the IOL, and as well, and also it is cheaper than the iris glow lens. So let me start and tell you my technique in using Yemeni. I start. In this case, I removed the iris hook. Sometimes we use iris hooks in subluxated cases. And then, sorry, it seems I have a problem with my video that is interrupted.
Yes, sure, you can see it.
You can see it's playing before it stopped suddenly. So I started taking my marks over the cornea to determine the sites of entry of the needles. I used 2 needles in this technique, 2 separate needles, one for each entry, and I enter 1.5 millimeters behind the limbus and not 2 millimeters as in adults. As you see, in this case, I left the bag before implanting the IOL because it was my very first cases, and I was afraid for the IOL to fall behind, and I left the bag and I left it to be removed at the end after IOL implantation. And then I implant the IOL in the anterior chamber with the leading haptic over the iris and leaving the trailing haptic outside the eye. Sometimes I use AC maintainer only if needed, because I always try to minimize the manipulations and to reduce the openings of the cornea. And if it's not needed, I do not use it. And I start first by engaging the leading haptic. It's better to try the needle and the haptics outside the eye before you start your technique. And then I try to engage the leading haptic first, and I use a 20 gauge retinal forceps or even smaller forceps if it is available. I think it is easier to engage the leading haptic than to engage the trailing haptic, as you see. And I start, after engaging, I start to pull out the leading haptic outside the eye slowly. And then cauterize the haptic. Sorry, I have a technical problem in the video. I don't know what is it. And then cauterize the haptic. To make a bulb to prevent its slippage of the intrascleral tunnel into the EC again. And then it's time for the more difficult haptic, which is the trailing haptic, to be engaged into the needle. Usually it was described to engage the haptic inside the anterior chamber, as you see. And for me, it was the more difficult step than the leading haptic. And I will show a modification at the end of the video that would make this step more easy. And that was how to take the haptic outside and cauterize the cauterize the haptic, I'm sorry. Can you notice the ballooning of the conjunctiva that happened on the right side? It's a common situation, common problem that could happen in pediatric age group because of the tenon. And so if you have this problem, you can expose and excise the conjunctiva and expose the sclera to see what you're doing if you had this appearance. Fortunately, I was lucky in this case, I did not have a large ballooning to excise the conjunctiva. And that was the how the lens look. And then I remove the bag after with the anterior vitrectomy after I finished my the IOL implantation, and it is actually a surgical preference, but you know, in the next cases, I stopped doing this because I'm no more afraid of the falling of the IOL backwards in the vitreous. Sorry. This is another case where I removed the bag first before implanting the, sorry. Just a second. Just give me a second to fix the problem, please. And this is another case where I removed the bag before starting to implant the Yamani technique, to use Yamani technique. You know, in those cases, I learned new tips that I open a corneal wound at 1 o'clock to make the engagement of the leading haptic more easy. And I learned another step and tap and modification to engage the trailing haptic. Let me tell you the modification. This is how I opened at 1 o'clock hour to make it easy to engage the leading haptic. And there is a new modification that made by Dr. Rasha. She advised to engage the trailing haptic outside the eye, and it made this easy, this step more and more easy for me. And this is how I do Yamani technique in a pediatric age group. And I followed up the cases, and I had a good and stable results with very few complications. And I hope you all benefit from my tips and the tricks in doing Yamani technique in pediatric age group. Thank you. And now let's raise the discussions, questions, and everything about the conventional techniques, whether to have the to do the iris glow lens or the intrascleral Yamani fixation of the IOL. And Dr. Nihal, please, your comment.
Actually, I don't have any experience in scleral fixation and Yamani technique. So I'm going to be a little bit biased to the lensectomy and maybe the secondary iris glow lens implantation. But definitely, if you master a technique, then go for it. And you have to go for the better in your hands. So I'm not a fan of scleral fixation, and I'm not a fan of Yamani technique in children, because I saw many cases which I didn't operate, but actually they were referred for complications. I did see many complications for scleral fixation in children after Ectopia Lentis.
You don't find indications.
I lack experience in it.
You don't find indications in your practice that you unavoidably need this technique?
Yes, of course. Sometimes when you have, for example, a trauma, you don't have a scleral support for secondary IOL implantation. You don't have an iris in order to put an iris glow lens, whether anterior or posterior. So you are left, and the baby gonna be left like that, or the child gonna be left like that, aphakic. So maybe you are forced to do a sort of scleral fixation. So definitely, there is an indication, and in not all cases. So it's variable. The surgery for Ectopia lentis or subluxated lenses is extremely variable.
Thank you. Thank you, Dr. Nayal. Dr. Ken, do you find any indication or situations you need something other than the phakic, the iris glow lens for correction of the pediatric aphakia? Please unmute yourself, Dr. Ken.
So what I would say is that there's a lot of gray in medicine. It's very rarely black and white. In my experience and in the circumstances that I have worked, I have been able to do a lensectomy. Sometimes I do a primary iris clip lens. Most of the time I do a secondary iris clip lens. Sometimes just contact lenses are fine. It is very, very rare for me in my circumstances to come across a situation where I cannot handle the situation either with an iris clip lens or with a contact lens or aphakic correction. So that doesn't mean that other practitioners don't have situations where they have to do something. So with that caveat in mind, my concern always is any scleral fixation, whether it's with glue, with the flap technique, the Yamani technique that you're talking about, or the non-flap technique, the intrascleral technique, they all have their disadvantages in children who have a connective tissue disorder because the sclera is not normal. But if it's the only thing you have and there's nothing else you can do, the parents can't afford glasses, or the child won't wear glasses and they can't get contact lenses, then you're stuck between a rock and a hard place. The only thing is that often in the Fibrinium gene mutations, the eyeball is actually quite long. So the power of the eyes that you're giving them is not like the +20s or the +18s. It's often +8 or +7. So maybe those aphakic glasses are a little easier to wear.
Yes.
But there's a lot of gray in this area, depending on the circumstances that you find yourself in. So I don't want to criticize anybody or anyone for doing that. In my hands and in my experience, I've managed to avoid it. And like Dr. Nihal, unfortunately, I've seen a lot of complications. They come to me for second or third opinions, and often by that stage, the eye is pretty damaged.
So you do not doubt that only the complicated cases are referred to you, and the nice cases go and complete the follow-up with their surgeons?
I agree. No, I think that's absolutely right. I think that's what happens. There's people are not going to come to me for a second opinion if everything went well.
Yes, sure. So, Dr. Ayman, what do you think about the iris glow lens? Do you find the severe iritis after using them in correction of the pediatric aphakia?
I think that's why I prefer to start with the poll and ask the audience opinion. As exactly Dr. Ken said, it's hardly a black and white. And in many cases, I start looking at the patient and thinking, what is the best for this patient? I know that we have a risk of iritis. We're doing this in cases with regular pediatric cataract, for example. We don't touch the iris, we have a severe postoperative iritis if we touch the iris, and then here we have an manipulation to the iris. Yes, we have a problem with this. And interestingly, a point that Dr. Ken has mentioned, many cases have a real high myopia of such cases. And when I found the biometry is quite a small number, I get encouraged to leave this patient a fake and just fit the patient with bifocal or multifocal glasses later on, if I find that the power is not significantly high, and avoid all the hassle of implantation, whatever iris fixated or sclera fixation. I know also the risk of the endothelial cell loss while implanting this anterior. It's a kind of anterior chamber IOL. So I know some people prefer the fixing the artisan in the posterior surface of the iris, but I think this will have, although it's more away from the endothelium, yet I believe it will cause more uveitis. I haven't tried it. I have a feeling that it gives more uveitis. I don't know if any of our guests have an experience in putting. I think Dr. Nihal has tried this for a while. What do you think about putting the glow lens in the posterior surface of the iris? Could be safer for the endothelium, but
I think we will have a discussion. Dr. Nihal will tell us all about this in your presentation, right, Dr. Nihal? So we do not want to go to Dr. Nihal's presentation and before she says it. And I have many questions in the Q&A box about the retropupillary artisan and the antropupillary artisan, and you will all learn a lot about all your questions, but I could not overcome and pass to the all the fans of the iris claw lens without having comments from all of you, all of the panelists on the Yamani technique, and a lot of criticism, as I know and as I expect. And now let's go ahead and start with Dr. Ken talk, and we are all too excited to hear Dr. Nihal lecture and know all the answers. And now I will listen to Dr. Ken about his preferred technique first.
So this is my preferred technique. I actually like to use the vitrector. I think it's an easier technique. So you make the first entry, switch off the cutter, and now everything you're doing is inside the bag, everything. And because it's inside the bag, you are not touching the vitreous. Look, it's very important as a surgeon not to concentrate only on where the tip of your instrument is, but to also have an overview of what's happening to the other parts of the eye. So if you watch the iris edge, the pupillary edge, it never moves. If you are doing this procedure and inadvertently you have caught some vitreous, you would see flutter of the iris here or here. Training young surgeons to look at the whole eye is actually the most difficult thing I have to do for my fellows, because they're concentrating so hard on the tip of the action that they forget that often in a movie, it's what's going on in the background that tells you what's about to happen. So it's really important to train yourself. Obviously, you've got to look at what you're doing. I'm not saying don't look at what you're doing, but look at the whole eye all the time. And Dr. Ayman, I have to disagree. I think using a capsulorhexis forceps, you actually put the lens at risk of dislocation because of the stress that you put on the zonules when you do your rhexis. So I don't like to do that. The other thing is that my maximum vacuum here right now, when I'm buried in the lens, can be as high as 400. But as soon as I have taken the lens material and I've emptied the bag, I then drop it to 150 max vac, to then take the bag followed by the vitrectomy. Now, one of the things you've got to remember is in cases where there is a connective tissue disorder, especially related to fibrillin 1 gene mutations, the vitreous is abnormal. And when you take the vitreous, there are simple tricks that you must remember. When you've finished doing your vitrectomy, never come out with your vitrector first, because the inflow of the infusion will push the vitreous to follow the vitrector as it comes out, and you'll get a strand at the wound. You should always take out the infusion first, and with minimal aspiration, have your cutter on and come out and sweep like this with the cutter facing up as you come out. That's the best way to avoid vitreous coming into your wound. The other thing is, whenever you do these procedures, I tend to operate from the top or temporally. You should always be facing the area to which the lens is dislocated. So the lens is dislocated nasally, you sit temporally. If the lens is dislocated superiorly, then what you do is you put a suture here and rotate the eye so that what was superior now becomes nasal and you approach it temporally. This way, like Dr. Amen said, you're always pulling against a fixed zonule rather than no zonule. And this is the way I eventually take out all of the lens matter and then take out the bag and do the vitrectomy. Please remember that the bottle height that you use will affect the pressure that you put on the vitreous to come out. So you want a good infusion, but you don't want a bottle height that is too high. So normally around 40 to 50 centimeters for me is what I use my bottle height on, but that depends on the gauge of your irrigation. If your irrigation is 20, 40 is plenty. But if your irrigation gauge is something like 25, then you do need a higher bottle height because that gauge is quite small. And once I've done that, and I want you to notice all the way through this, the iris did not move. Thank you.
Thanks, Dr. Ken. And I think we will have now a small debate between Dr. Ken, preferred technique, and some changes with from Dr. Nihal technique. And now it's time for Dr. Nihal, preferred technique and preferred approach. Dr. Nihal, please start sharing your screen. We have many questions about the preference of retropupillary artisan or antropupillary artisan, and we're looking forward to hear from you, Dr. Nihal.
Bismillah ar-Rahman ar-Rahim. I'm going to speak about the controversies of surgical management of Ectopia Lentis. As we all know, Ectopia Lentis is still, as a management, carries many controversies. And actually, before dealing with surgery, we have to go for good examination, and surgery going to depend upon many factors. Number one, it's going to depend upon the direction of subluxation, whether it is a horizontal or a vertical subluxation, or a diagonal up and temporal, up and nasal, down and temporal, down and nasal. It depends upon the presence or absence of cataract. It depends upon the severity of subluxation, whether it is a mild subluxation or moderate subluxation, whether the lens is bisecting the pupillary area, or a severe subluxation like that, and nearly here the pupil is totally or subtotally aphakic, and lens here is extensively subluxated behind the iris. It depends also the surgery about the condition of the zonules, whether it is perfectly intact like that, is it intact and elongated, is it elongated and disrupted, or elongated or extensively disrupted like that. And we have also to comment or to see the thickness of the zonules. Is it thin or thick like that? And the branching, when it is inserted to the equator of the lens, you have to see it. And also to see whether this elongated zonules of a uniform thickness, or it is of a variable thickness. It is thick at the equator and then thin at the periphery. We have to comment and we have to see the extent of zonular dehiscence. Is it mild zonular dehiscence or moderate or severe zonular dehiscence as here, or extensive zonular dehiscence? And having here, can you see a vitreous pathologies and a vitreous liquefaction that may increase, or you should be aware that there will be increased risk of retinal detachment in these cases. Also, it depends upon the curvature of the lens or the subluxated lens. Is it smooth or is it irregular surface? And this irregular surface, is it due to trauma or sometimes due to colobomatous lens? And if you are sure it is a colobomatous lens, sometimes it is not associated with cataract. And in many cases with lens coloboma, it is associated with congenital cataract. And not only congenital cataract, as you see here, this is a lens coloboma associated with here elongated zonules, also elongated ciliary processes and persistent papillary membrane. An important issue that actually gonna change the decision for surgery is the pupil central with Ectopia lentis, or is it eccentric in some cases of Ectopia lentis? And in some cases, we see what is called Ectopia lentis a Papilli. The lens is subluxated in one direction and the pupil or the correctopia is in the opposite side. We have to know, is it associated with iris coloboma? Because if it is associated with iris coloboma, this is a colobomatous lens. It may be associated with disc and chorioretinal coloboma, and there's going to be no need to go for surgery in these cases. Is it associated with congenital aniridia? And sometimes with Ectopia lentis and congenital aniridia, the lens just so minimal lens opacities, or as here, mild opacity in the center, maybe associated with anterior polar cataract, maybe associated with spoke-like cataract, and extending into even a total cataract with Ectopia lentis and congenital aniridia, and sometimes intumescent cataract, touching the back surface of the cornea and presenting with secondary glaucoma. And in many cases, we see it sometimes a sort of absorption of the lens, and it becomes like a senile hypermature cataract or a membranous cataract, as in this case, and surgery in these cases is quite difficult. Also, we should screen whether it is associated with systemic anomaly or not, because management is going to change massively, like, for example, Marfan Syndrome. And we have to know, as Professor Ken said, to go for a genetic counseling, or at least to know whether there is a family history for Marfan syndrome, as in this case. Why? And also we should examine the parents, because, for example, here the mother gave a history that she lost her right eye after developing retinal detachment. So you have to know that when you go for surgery for the child, you have the risk of developing retinal detachment after surgery. Also, is it associated with Weil-Marquesani syndrome, apart from being obese and short stature and small square hands and small square feet? The lens is not only ectopic, but it is microspherophakic. And also, you should exclude traumatic Ectopia lentis. Traumatic Ectopia lentis, you should know that you're going to have a very good zonules over there, and maybe a part of the zonules is only disrupted and maybe associated with other pathologies as the traumatic cataract or lens fibrosis, and sometimes associated with damage to the iris, as here sphincter papillary damage or iridodialysis, and sometimes associated with vitreous in the anterior chamber, that sometimes it is hemorrhagic. So we have a varieties of presentation, and of course there is a varieties of surgical technique. Along the past 20 years, or 20 years ago, I used to do some surgeries, like, for example, CTR and PMMA IOL in the sulcus. In these cases, after performing anterior capsulorhexis and implantation of a CTR inside the capsular bag, together with a posterior capsulorhexis, and then implantation of a PMMA IOL in the sulcus, supported by the CTR. Few weeks after surgery, few months after surgery, she's fine. Years after surgery, these children were okay. And you can look here, years and years after surgery. This is the CTR and the IOL supported by the CTR. But we faced a problem. Years after surgery, when these eyes just have a minor trauma, these intraocular lens may subluxate easily. You can see here, this is the CTR inside the capsular bag and the anterior and posterior rexes. And here, a subluxated IOL after eye trauma that we have to go again for a secondary surgery to penetrate the eye and reposition the IOL in place. Moreover, in these cases, especially when we had Marfan, even when the capsule tension ring was possible to centralize the capsular bag and perform the anterior and posterior rexes and implant the PMMA in the sulcus, and primarily like that, it looks fine. Years and years after surgery, owing to the ongoing pathology of Marfan syndrome, if you see here, there is subluxation of the whole capsular bag with the CTR in one direction and subluxation of the IOL to the opposite side. So we had to go with a Prolene suture to suture the whole capsular bag to the sclera. And here you can see here, this is the Prolene suture to centralize the capsular bag and then reposition the IOL. Then after 10 more years, and this was done 20 years ago, can you see here, this is extensive sommering ring that developed along the 10 years follow-up, but the capsule tension ring and the clear visual axis was maintained. Another technique we used to do is capsule tension ring and multi-piece IOL inside the capsular bag. This is the capsular bag with the capsule tension ring and implantation of a multi-piece intraocular lens inside the capsular bag. Few months after surgery, we had a posterior capsular opacification. That's why we didn't do this technique except in older children where it is possible to go for YAG laser capsulotomy. And in younger children, after anterior rexes and implantation of the CTR, we used to do a posterior rexes before implantation of a multi-piece intraocular lens inside the capsular bag. And in some cases, when we faced that the capsule tension ring didn't centralize the capsular bag, we used to suture the whole capsule tension ring and the bag with a Prolene suture to the sclera under a scleral flap to centralize the bag and then perform a posterior rexes and implant the IOL inside the bag. And here how it appeared after surgery. But what happened? Years and years after surgery, yes, the IOL is still in place, and this is the posterior rexes, and we had a clear visual axis, but we faced the problem of a myopic shift. How can we go for an IOL exchange in these children when we have a compromised capsular bag? So, along now, 13 years ago, our preferred approach is lensectomy through anterior approach and then secondary iris flow lens implantation. In these cases, we go through a small corneal wound to make a tear in the anterior capsule, and then we go for anterior capsulorhexis, and then we hook the anterior rexes with a hook to centralize the lens. To facilitate irrigation aspiration, we go for hydrodissection, hydrodelineation, and then irrigation aspiration. And once we are in with the irrigation aspiration, we are never out until we finish irrigation aspiration. And then the capsular bag, we eat it with a cutter and perform anterior vitrectomy. You may say, why this technique and why the step of the iris hook? Just go in and eat it up or go for irrigation aspiration. Here, for example, this is an eye before surgery. Look here with the magnification, these are intact zonules. After performing anterior capsulorhexis and then hooking the capsular bag and centralizing the lens, look here, there's a sort of a tint in the capsular bag, separating the capsule from the cortex. Through this stent, you can go with the hydrodissection cannula, and you go for a perfect hydrodissection. It is exactly between the capsular bag and the cortex. This will facilitate massively the irrigation aspiration, gonna take just seconds. And once you are in, you finish all irrigation aspiration without even changing hands. And look here, after irrigation aspiration, look at here the zonules, and here with magnification, they are still there. What does that mean? It means there is complete stabilization of the iris lens diaphragm. There is no fluctuation in the anterior chamber, which definitely will lower the incidence of retinal detachment later on. It means there is no vitreous did prolapse through these zonules. You didn't interrupt the vitreous. And then look here again, this is after irrigation aspiration, intact zonules. This is another case, perfectly intact zonules. This is before irrigation aspiration, and this is after irrigation aspiration, as if you didn't touch the zonules. Even in eyes with persistent pupillary membrane, look after irrigation aspiration, they are still there. It means that you did least manipulation. In eyes with partially disrupted zonules, they remain there. This is a partial disruption of the zonules after irrigation aspiration. And it's not only in thickened zonules, where you have intact zonules after irrigation aspiration. In eyes like this, look before irrigation aspiration, you have very thin zonules. After irrigation aspiration, they are still there. It means, again, no vitreous prolapse. Look here, this is an eye. Can you see? This is the shadow of vitreous liquefaction here in a vitreous pathology. After irrigation, still the zonules are there and vitreous didn't prolapse. And even the eyes with partial zonular dehiscence, you are supposed to have vitreous prolapse from this area. After irrigation aspiration, you still have the area of zonular dehiscence with no vitreous prolapse. And then you go again for eating up the capsule bag and perform vitrectomy. You may say it's quite difficult. There are some tips to make this surgery easy. When you penetrate to introduce the iris hook, just introduce the tip of the MVR in order to make a very tiny one. And then when you introduce the hook, you may use a Y-shaped cannula in order to push the anterior axis towards the hook. Push more, push more, push more until you are beyond the edge of the tip of the iris hook, so you can hook it very easy and then pull the capsular back and centralize the lens and proceed with a hydrodissection. And here how it appears after irrigation aspiration. The zonules are beautiful there, indicating least manipulation. And then you eat it up with a cutter and perform the vitrectomy. And whatever the direction can be anyway, to the right or to the left here, this is the iris hook. Again, the Y-shaped cannula, pushing it again towards the hook and facilitating hooking up the lens, centralizing the lens, and then proceeding, as I told you, beautiful zonules after irrigation aspiration, and here with a magnification, and then eat it up again with a cutter. This is, it also have an advantage. Can you go for this technique even in eyes without zonular attachment? Yes, look here. This is an eye nearly without any zonules. Still, I can go for anterior axis and hook the bag. And look here, after irrigation aspiration, there is complete folding of the capsular bag because there is no zonules. But look here, with magnification, no zonules. And still you can go for this technique easily with a vitrectomy and here at conclusion of surgery. I do it even in cases of Ectopia Lentis with congenital glaucoma. Same technique, anterior axis, hooking of the capsular bag, hydrodissection, after irrigation aspiration, and here the capsular bag eaten up easily with a cutter, and here at conclusion of surgery. you lower the risk of choroidal detachment and choroidal hemorrhage that may occur after lensectomy in these cases. This is the picture of the eye that appears immediately after surgery, and I fit the babies with aphakic spectacles. And as Dr. Ayman said, or Dr. Kanishan said, they usually have a long axial length. They may be fitted with a hyperopic spectacles of +10, and you can fit them even with multifocal lenses in these cases. And in some selective cases where I prefer to implant a secondary iris glow lens, it's again a simple surgery when you go it as a secondary procedure. You have a beautiful constricted pupil. You insert the pediatric artisan inside the eye, and then with a 21 gauge forceps, you hold the lens and you centralize it over the pupil, and then with a special 22 gauge iris forceps, you go through the side port and you incubate a good amount of the iris tissue into the artisan lens, and then from the other side port, you make another incubation to the other side. And then we make a peripheral iridectomy. You have to ensure very good grip on both sides. Here, how it appears after surgery, few weeks after surgery. Here, few years after surgery. Here, 5 years after surgery, and it did start to appear some atrophy at the site of incubation of the artisan. And here, another 5 years after surgery, 10 years after surgery, there is extensive fibrosis, but the IOL is still in place. But we have some cases that the IOL did penetrate the whole iris tissue there, and it did subluxate in some cases. So if you're gonna go for artisan lens or iris glow lens in the anterior chamber, you have to ensure a very good grip from both sides. And here an eye, posterior chamber iris glow lens, and these are the site of inflammation from the back surface of the iris. Here, a few years after surgery, you can see here the incubation. Here, 5 years after surgery, there is atrophy of the iris. And here, 10 years after surgery, what happened? The haptic of the iris glow lens did appear in the anterior chamber. And here, another eye that the haptic did appear, but the lens remained in place. And this is 10 years after surgery. So if you're gonna put posterior chamber iris glow lens, you have to ensure very good grip from both sides to avoid disincubation in the future. And the last technique which I do for Ectopia Lentis is multi-piece intraocular lens with a cut haptic and inserted inside the capsular bag. Originally, I saw this technique performed by Dr. Ventura from Brazil, and that was in 2011 when I met him in New York. He proposed cutting one edge of the IOL, of a multi-piece IOL, and then inserting this intraocular lens inside the capsular bag of an ectopic lens, so the IOL optic comes in contact with the equator of the ectopic lens. And as a result of this, you're gonna have a very well-centered IOL with the least manipulations. Actually, in an Alexandria University, or I did some modification in the indication for surgery and also in the technique. I implant or do this technique only in older children, and when I'm so sure that it is not associated with any metabolic or a systemic disease, so the majority of cases are either isolated or they are traumatic cases. And of course, in older children. Why? Because we're gonna leave the posterior capsule intact. So they are liable to have a posterior capsular opacification, which I can manage with the YAG laser in the future. So I only do these surgeries if I have a mild Ectopia Lentis, a moderate Ectopia Lentis, where when you go to implant the IOL and the optic gonna be in contact with the equator, as a result, the IOL will appear to be central. And they have an error of refraction that is not amenable to be corrected by spectacles. And you have to be sure that this error of refraction is a lenticular origin and not, of course, of a corneal origin. How I perform this surgery? I perform anterior capsulorhexis, and then again I hook the capsule back and centralize it in order to preserve the zonules. And then through this tent, I go for hydrodissection. Irrigation aspiration, as I said before, it's going to be very simple and easy. And after irrigation aspiration, I cut one haptic of the acrysoft, the multi-piece IOL, and then I implant this IOL inside the capsule bag. Look here, this is the equator of the lens, and this is the cut haptic of the IOL. If you look to the lens, it is well centered in the pupillary area, but here the anterior capsulorhexis has to be widened. So I cut it with the micro scissors, and then with the microrhexis forceps, I enlarge the anterior rhexis in order to expose the central part of the IOL. This is another case after anterior capsulorhexis. Look here with the magnification, the zonules are intact, and I want to keep the zonules intact. So I hook the capsular bag, make hydrodissection, irrigation aspiration. After irrigation aspiration, now we cut a haptic here and implant the IOL inside the capsular bag. It's very easy and a simple technique, and the IOL is very well centered. But again, we enlarge the anterior rhexis by a micro scissors, and with the microrhexis forceps, we enlarge it to expose the central part of the IOL. Here at conclusion of surgery, and here 1 year after surgery, the IOL is still in place and beautifully centered. This is an eye again here before surgery, and here at conclusion of surgery, the IOL optic in contact with the area of subluxation, and this is a cut edge, but at the final result, the IOL is very well centered. Here, an eye, few months after surgery, can you see the IOL is beautifully centered? And if you look here, the optic in contact with the equator of the lens and the zonules are intact. There is a close-up here. This is a high magnification. This is the optic. This is the cut edge of the haptic. And these are the zonules perfectly in place. 1 year after surgery, the IOL is still central. The IOL is still centered and the zonules are still perfect, but the child developed posterior capsular opacification. It's not a problem because he's an older child where I can go easily for YAG laser capsulotomy whenever I want. So finally, to conclude, management of Ectopia lentis in children is still controversial. And the choice of surgical technique depends on many factors, as I told you. And we have to ensure very long-term follow-up in order to decide the best or the ideal surgical approach that have the least complications, and also should allow IOL exchange in the future if myopic shift to occur. And thank you very much for your kind attention.
Thank you, Dr. Nihal, very much for your very interesting and you really have many points that needs discussion and the questions from all of the audience and from me and for sure from Dr. Ayman. But I want to ask you a few questions, you and Dr. Khan, to see what's your different opinions about the same question. But first, I want to know the opinion of Dr. Khan. Did you do the multifocal IOL as Dr. Nihal? Do you agree about this technique with cutting of one haptic? Please unmute yourself, Dr. Khan.
So what I've learned is that I've been fortunate enough to travel the world lecturing. I've spent a lot of time in China, Indonesia, India, even the Middle East. And one of the things I have learned the hard way is it's really important when you describe a technique that is not well known to publish the technique, because as flawed as our peer-reviewed mechanism is. I'm sure Dr. Nihal wouldn't want, of the 144 people listening right now, tomorrow, if they had a dislocated lens case, to go ahead, take an haptic, cut one lens and of the haptic off and just try it to see if it works. Because, you know, she's done this because she's very experienced and she's seen someone describe it and she's gone away and thought about it. And I think that my take on this is this: I have never done it. I've never seen a paper published on it. So until I see a paper that I can have a look at the complications, the outcomes for myself, and then assess whether it's a bona fide technique that I would like to try, then I can't comment on it. But I'm sure Dr. Nihal would not want people who are not experienced in sublux lenses techniques to suddenly start trying this without any kind of control about what the outcomes are. I can't imagine that she would want that to happen.
Okay, let's. Dr. Nihal, would you like to answer? Comments?
Definitely, Dr. Ken, as I told you, this is it should not be a usual practice. I do it in very selective cases when I have very good zonules there. So maybe the majority of the cases are traumatic. So, and I do it in older children. I have follow-up now for more than 6 years in these cases, and they are doing fine because I selectively operate these cases. It's not a general rule to have an Ectopia Lentis to go for surgery like that. So definitely, I'm very selective.
Yeah. And I think that's my point, is that, you know, out of the hundreds that you do, I don't know, maybe there's a handful that reach the criteria to do this. And I think, so I think what we're agreed on is this, is that this technique may be useful in selected cases. I think that we agree on that. I haven't done it.
Okay, thank you, Dr. Ken. Now we have rapid questions for both Dr. Ken and Dr. Nihal to see their preference. The first question: what is the earliest age do you implant the iris clone lens? Dr. Nihal, please. The earliest age.
4 years.
4 years. And Dr. Ken?
Yeah, I already typed the answer. Actually, I put 4 years as well.
Okay. Dr. Ayman?
Yeah, I agree with them, but I myself haven't done it less than 7 years old. I haven't done this before this age.
Okay. So the other questions: do you only implant pediatric size artisan, or what if you do not have pediatric size artisan available in the market? Dr. Nihal?
Actually, it was available in market, but I've been told that it will not be produced again, which is a major loss. So again, selectively, I implant when I have a large corneal diameter and I have a reasonable depth of anterior chamber. But as Dr. Ken said, many cases have flat corneas. This, I will never implant iris flow lens in these cases. And among the hundreds of cases we did in Alexandria University, we follow up these cases along the past 13 years with specular microscopy, and they are still doing fine. Those who are implanted in the anterior chamber, and we follow them up for the glaucoma, for the uveitis, for cystoid macular edema, for those who are implanted in the posterior segment. So implanting an iris clove lens, a pediatric size, it was marvelous. But I don't know in the future, what about the adult size? So the age definitely going to increase. We will not implant an adult size artisan in a 4-year-old child, unless if I have a large corneal diameter and a deep anterior chamber, which is going to be a loss, major loss, that they will not produce a pediatric size artisan again.
So, Dr. Ken, would you implant adult size in pediatric age group, or you don't implant at all if you don't have a pediatric size artisan?
I think the question is, respectfully, the question is the wrong question. The question is what eye size, anterior chamber depth, white to white, can take an adult size iris clip lens? That's the question, right? Because if you have, I have adults who can't take an adult size lens because their parameters of the anterior chamber, you want an anterior chamber depth of at least 3.1 millimeters minimum, right? So if you don't have 3.1 millimeters and you've got an anterior chamber depth of 2.2, frankly, I don't care even if you're putting a pediatric one in, you're at risk in that eye of problems with the endothelium. So 3.1, you want 10 millimeters white to white. Some people say 9.5 is fine for the adult. I worry about that. So I think the question is what are the parameters of the eye that you're thinking about implanting, rather than whether it's a child's eye or an adult's eye. But I agree with Dr. Nihal. I think it's going to be a problem as the pediatric size implant becomes unavailable. I think it's going to be a problem. I think that there will be a couple of companies from Asia that will start to produce it and supply it because they'll know that there is a need. So I think there'll be a short time when we don't have it, and then it'll come back, the smaller size one, is what I think. I would say in the last few minutes that we have that iritis has not been, in my experience, a problem. I'm very surprised because the iritis that you get when you get iris prolapse is because the iris has been exposed outside the eye, which is the unnatural environment. In iris clip lenses, when you do the iris clip correctly, and whether you use forceps or whether you use the enclavation needle, there's not much trauma. I mean, I can't remember ever getting a bleed. I can't remember tearing the iris. So maybe I've just been lucky, but I really have not seen iritis. There is a very good paper written that showed that if you have an anterior chamber, sort of anterior placed iris clip lens, and compare it to the unaffected opposite eye, that the loss of endothelial cells is not significantly different at the end of 5 years. So the issue of the endothelial cell count, I believe, is important, but is not as deleterious or worrisome as people make it out to be. Now, if you had trauma, it's a different story. And the loss of the endothelial cells is directly proportional to the length of the scar in the cornea. So I think all of those issues, I think evidence base is really important to help advise what we're doing. And I think that's important to do.
So thank you, Dr. Ken. So my last question, and I wish you like my question this time. Do you prefer retropupillary or antropupillary fixation of the iris glow lens? What is your preference?
I've done both. In Europe, I could do retropupillary. In the US, the FDA have only approved anterior fixation. I think, look, anatomically, it looks nicer if you put it retropupillary, and it makes more sense that it's safer in the long run on the endothelial cell count. But again, it's not happened to me, but I can imagine if it dislocates, and I think Dr. Nihal was saying that she had some experience of this the other day, it's more difficult to replace. Whereas if it disenclaves anteriorly, it's very easily to refix. So I don't, my own experience is they're both as easy to do, but physiologically it makes more sense. Now, the only time the retrofixation is a problem is if you don't flip the lens. And I have had a child sent to me for UG syndrome with a retrofixated, but they forgot to flip the lens. So the curvature was rubbing up against the posterior pigment epithelium.
Okay, thank you, Dr. Ken. And Dr. Nihal, what is your preference, retropupillary or antropupillary
Well,
fixation?
I used to do both, and I still do both, but during the 2 years follow-up or 13 years follow-up, what happened? When children are exposed to eye trauma, and this eye will disinclavate, when the posterior chamber intraocular lens dislocated, will dislocate into the posterior segment, and you need a vitreoretinal surgeon in order to get it back again and refixate it. But in cases of anterior chamber iris flow lens, when it dislocates or disinclavate, you can easily refixate it again by yourself into the, and it's a simple surgery to deal with the complications. So it's only related to the complications and eye trauma that may occur in these children. Because despite this eye trauma, they can de-inclavate easily. But as a technique and as a result, if they are not exposed to trauma or disinclavation, both are feasible and both are perfect and both are easy to perform.
Okay, thank you, Dr. Nihal. I will present after a few minutes a case that would raise this debate and to engage the audience in the choices, whether they prefer the antropupillary or retropupillary fixation. And now it's time for the last talk of Dr. Ken. He will talk about Ectopia Lentis, Papilli, or special forms of Ectopia Lentis.
Well, I have to tell you, Dr. Heba, you told me we'd be finished by 5. I have a case in the OR in 10 minutes. You told me 5 o'clock. Okay, I'm good. I apologize, but I stuck to the timings you told me. So I'm going to show you my case, and then I'm going to have to respectfully leave. I am so sorry, but you told me 5 o'clock. So I took you at your word. All right, let me share. Let me share this. Okay. So I'm just going to show you a couple of cases. This is a child who has hardly any zonules, and the lens was very dislocated, very wobbly. I was a bit worried it may fall into the back. So what you do is, here's a very simple technique. You take 2 30-gauge needles and simultaneously you skewer the lens. Now that you've done that, you leave them in place, and then you carry on as you're doing. I'm going to place a infusion, and then I'm just going to do the lensectomy technique. It's a very nice technique to stabilize the lens while you take the lens material out. And for the sake of time, then I'm going to move on. So it's exactly the same as previously, but this is just a stabilization technique, that's all. Somebody was asking me that, you know, if you put an infusion in, you hydrate the vitreous. That's true, which is why you have to make sure that when you've done your vitrectomy, you're not bringing out the cutter first, but the infusion. But you've got to have your AC deep, right? It's very, very important that you don't damage the endothelium when you're doing this technique or this surgery. So again, for the sake of time, let me just cancel this out. I'm hoping I can cancel it out. Yeah. So this is a case of LTBP2. So how do I know this was LTBP2? I didn't at the time, but I did the testing afterwards. Very big cornea, and microspherophakia. And what I want you to notice is that the lens is really wobbly. I mean, it wasn't like this in the clinic. By the time the child gets the OR, look at this. Now, if this was an adult, that lens would have floated back by now. But it tells you 2 things. It tells you that the vitreous must still be formed, right? It's not possible to have a syneretic vitreous and have the lens attached like that, or not rather attached, supported like that. And then the other thing I want you to notice, very important, is the iris is not moving. If at any stage during this procedure, the iris moves, flutters, you have to stop and hand it to your vitreoretinal colleagues as a referral. But what I want you to notice now also is life is full of complications, and you have to be aware of how to deal with those in a safe way. All right, a few air bubbles. I can deal with those. Now I'm in trouble. So this is where your ability to look at the whole eye becomes imperative, right? I have got the lens caught in my vitrector. I'm not cutting, I'm just aspirating. I make an entry with my left hand. So this is the advantage of having an infusion, is that it gives you one spare hand. That's how I felt. And what you want to do is, now I'm going to use visco to pop the lens into the anterior chamber. But I want you to notice something. When you run into difficulties, your hands should stop moving. The more you flap around when you have a difficult case, the greater the chance of you developing a bigger complication. And here you can see now, very little movement of my hand. I am cutting and aspirating, and I am watching the iris all the time. There is no fluttering of this iris whatsoever. And that tells me that I have everything under control. I'm using my left hand to protect anything from falling behind. And that's just a case that I wanted to share with you to show that complications happen, but how you react to them determines what happens. Don't panic, stop and slow down and think about what you need to do. So on that note, I just want to talk about Ectopia Lentis at Papilli. This is a paper that I wrote with colleagues of mine from Oxford too many years ago now that I'd care to remember. I think it was 1999 it got published. This is a 34-year-old woman who has pupils that are dislocated downwards, and her lens had by this time dislocated in the back of the eye, but it had dislocated in the opposite direction. And what we showed with UBM is that in the direction that the pupil is dislocated or ectopic, the pupil, here, there is a retro iris membrane. And in the opposite direction, there are no zonules. So, there are zonules, but there are no zonules here. So the lens gets pulled this way and the iris this way. And this turns out that the Germans had reported this in 1908 in a post-mortem specimen and also noted the same thing, but they thought it might be an artifact. And so whenever I have a case of Ectopia lentis and Papilli, if they're very young, I actually try to cut this so that the pupil can centralize with dilation without having to disrupt the pupil sphincter. And this is just an advert for a webinar on Saturday if you're interested on aniridia. So thank you so much for having me on the webinar. It's been phenomenally educational and very, very enjoyable. Thank you.
Thank you, thanks, Dr. Ken, for your time. Thanks.
No worries. I think I have another 5 minutes, I'm being told. So if there are any questions or Dr. Nihal wants to comment at all, please do so. I do apologize. It's just that You told me until 5. So.
We take more than the exact time for the webinar.
Okay, that's okay. That's all right.
So, Dr. Nihal, would you like to comment on Dr. Ken presentation?
Definitely, it's perfect presentation, Dr. Ken.
Thank you.
And me too, despite performing only lens surgery, but I really learned a lot from you. Thank you so much.
Oh no, same here. Same here. There's a couple of questions that people are asking. Do you want me to try and answer them before I go? Is that okay?
Yes, please. Yes, please. I did not want to waste your time.
No, you're not wasting my time. I apologize. I feel bad, but let me answer the questions because people have been kind enough to listen. It says, what is the most accurate method to measure the AC depth? A-scan, IOL master, UBM, anterior segment OCT. I don't know, what do you guys use? I use the A-scan, to be honest. And a UBM if I can put the child to sleep, but I'll often use the A-scan. What do you use?
For myself, the IOL master is doing most of the job. But the point is that should be a cooperative child to sit for this. That's why I'm not doing this kind of surgeries in a very young child. One of the causes, of course, not the only cause. What Dr. Nihal, I'm eager to listen to her experience.
Concerning Ayman, what?
The AC depth.
Depth. How we measure the AC depth?
Yes, well, actually, we use the UBM or OCT, and as Dr. Ken said, we don't implant unless we have at least a depth of 3.1 millimeters and white at least 10 millimeters in diameter.
Mm.
So there's a question about what are the parameters of the machines that you use to vitrectomize? That's a really good question, actually. So I'll tell you what I do, and then I'd be interested to hear what everybody else does. I use a cut rate when I'm doing this, a maximum of 1,000. I know some people have 5,000 cut rate per minute, but 1,000 is the maximum I go to. Normally it'll be around 750 to 1,000. My vacuum when I'm in the lens is up to 400, but then once I'm outside the lens, in other words, once the lens is gone, I drop it to 150. And I explained about the bottle height already. I don't know what everybody else does.
What do you think, Dr. Nihal? Do you have a comment?
Yes, well, it's because I don't go directly with the cutter. I go for irrigation aspiration first. So I use the usual irrigation aspiration parameters because I'm not afraid of vitreous prolapse. I'm centralizing the lens. So I go for irrigation aspiration with the usual parameters. And then afterwards, when I eat up the capsular bag and perform vitrectomy, I use a cutting rate of 650 or 750 maximum. I don't need a high cutting rate, and then I perform with a low, of course I lower the bottom to the maximum, and a vacuum of 200 or 150 to 200, like as if I'm performing a congenital cataract surgery.
So I see an interesting question. What about mentally retarded children? What are your IOL options, correction? He means options of correction of pediatric aphakia.
May I respectfully tell a story? About 19 years ago, I referred to a child as being mentally retarded. And the doctor who was with me said nothing, very kind man, and we talked about this child. And I was working at Great Ormond Street. That evening, I was leaving Great Ormond Street, and the same doctor was with his child, who was, as I had described, mentally retarded. And he came up to me, very nice man. He put his arm around me. He said, "You're a young doctor. It's better to refer to children as being developmentally delayed than mentally retarded, because the term retarded has an unkind connotation. And to us as doctors, we're not being unkind, but to parents, it can seem unkind. And it's a shame because none of us are unkind. So I would respectfully suggest that everybody, just think about it. Developmentally delayed means the same thing, but doesn't have any unpleasant connotations. I'm just expressing my own personal event 19 years ago that changed how I viewed the terminology. That aside, I would say that they're the most difficult children to deal with, because even if you put an IOL in, no matter what you put in, if they self-harm, they're at the greatest risk of dislocation of whatever lens you put in the eye. So they are my biggest worry. And I think that it's better if you can get a long-term or, like a 6-week or 8-week contact lens into them, or a 3-month silicone contact lens, than an IOL. But it's very difficult. But I have avoided putting implants in them because I'm worried about self-harm. Now, I've had 4 children who the parents are adamant don't self-harm, and I put iris fixated lenses in, and I've had no problems. So I think if the parents know the child better than you do. So that's my experience. I don't know what, and I would just preface, please don't mind me sharing my experiences with you, because these webinars, we're very remote. It's very impersonal. And I think it's important for people to realize that we're human beings as well as doctors, and that has an effect on how we think.
Yes, sure. Thank you, Dr. Ken. And then if you have a few minutes, you can attend my last case. If you have a few minutes in the webinar.
Go on, yes. Give me a second. I'll let them know. Go ahead. That's all right. I'll let them know.
So my last talk, it's just 4 minutes talk about the management of dislocated implanted intraocular lens in Ectopia Lentis patient. What if you are in your clinic and you have this appearance in a patient who walked into your clinic? You have a subluxated implanted IOL posterior chamber, whether it is artisan or even the scleral fixated IOL. To my mind, you have to start over with systemic evaluation and genetic counseling and everything, and examine sisters and brothers and everything. Don't forget, because you do not have the patient from the beginning with the cataract, with the subluxated cataract. Don't forget to start over with systemic evaluation and genetic testing. My case is an 8 years old girl who came with a history of cataract extraction and IOL implantation 3 years ago, and seeking improvement of her visual acuity. She had a right subluxated posterior chamber IOL, which I did not know the type of the IOL. It was not clear on slit lamp examination, and the patient had dislocated CTR previously implanted, and the left eye, she had subluxated posterior chamber IOL. And this was the anterior segment examination of her sister. And so that is the importance of examining all the family and start over with systemic evaluation. And preoperatively, in those cases, you have to be ready with your refraction and your IOL calculation with all the constant of the lenses that you might need after exploration if you cannot know the type of the previously implanted IOL. Be ready with refraction. The patient, the refraction was in the right eye was -2/-3 and axis 35. The best corrected vision in the eye that seems with severely damaged or lacerated iris was 6/24. The left eye, she had an isometropia -10/-4 with the axis 60 or 90. I remember the best corrected visual acuity was in the left eye that seems better with better iris, and in a better situation the visual acuity was 60, and so it seems that the patient had a left anisotropic amblyopia, you have to be ready with all the IOL calculation if you cannot determine the type of the IOL with different A constants, as I just said, and try as much as you can to determine the type of the previously implanted intraocular lens, if it is possible, by the UBM, by asking for UBM. So in my case, by UBM, I discovered that it was a subluxated retropupillary artisan. So let's publish the first poll, please. What would you do in this situation? You have a subluxated retropupillary artisan. Do you refixate it in its retropupillary position, or would you remove it and implant a new artisan anterior to the pupil, or would you remove it and use the same artisan and fixate it anterior to the pupil, or would you remove it and do posterior scleral fixation technique? Please, we want a heavy participation, and we would want all the audience preference. You have 10 seconds to choose your preference. And now let's see the audience opinion about this problem. So we have a split in the opinions about the same situation. The most chosen situation is to remove it and implant a new artisan anterior to the pupil, but there are no difference in the number of audiences. And I hope this time my video is played. So this is a 1 minute video of how you disenclavate the one point of enclavated iris globe lens. You have to hold the artisan lens quite well with the forceps, and then try to disenclavate the enclavated portions, that enclavated portion retropupillary. Actually, it is very silly situation. It's very difficult to disenclavate an enclavated point in the iris. You might cause iris atrophy, and this is how you disenclavate. Actually, cause a lot of manipulations, iris manipulations. And now I refixated. Can you notice that the convex surface of the artisan lens is upward? So there is no need to reverse the inverse the lens upside down. So the concave surface to face the iris to minimize the iris shaping. Already the convex surface was upward, and so there was no need to inverse the IOL. And then I re-enclavated the same artisan in the same anterior to the pupil. And let me show you how you think in this case. In this situation, you have to have your the measurement and the calculation, and to weigh out the change in the refraction that would happen if I implanted the same lens anterior to the iris, and it's to weigh out the advantages and the benefits against the induced astigmatism of opening a 6 millimeters lens corneal wound, and add -2 astigmatic correction to the patient who had already against the role astigmatism. And so in this case, I weighed out the difference in the refraction that would result in if I implanted the same lens anterior to the iris, and I find the patient would benefit more if I implanted the same artisan anterior to the pupil. So when I think in the previous debate, I have to think in all these aspects: the difference in the refraction, the way the patient will benefit, how far the patient will benefit from changing the lens into a lens anterior to the pupil with different A constant, and the refractive changes that would differ. And so in this case, I implanted the same lens anterior to the pupil. So it's time for the other eye. Under general anesthesia, I examined the patient more thoroughly, and I find that she has a dislocated CTR and subluxated retropupillary artisan. So it seems that the previous surgeon was trying to put CTR, and then he failed to fixate a three-piece IOL in the posterior chamber in the bag, and so he shifted and changed his plan and implanted a subluxated retropupillary artisan, and the patient had this severely distorted iris. So it's time for the second poll. Please share with us your opinion and tell us what you do if you were in the same situation. Would you remove the CTR, the old CTR and the retropupillary artisan, and reimplant the artisan anterior to the pupil? Or would you remove the CTR and the retropupillary artisan and implant scleral fixation? Would you leave the CTR as it is and remove the dislocated artisan and reimplant another one anterior to the pupil? Or would you leave the CTR as it is and remove the dislocated artisan and then implant scleral fixation IOL? Or would you do nothing for the patient? Please publish the poll. Okay. So please choose what is your preference if you were in my shoes. So let's see the results of the poll. So most of the audience choose to remove the CTR and the retropupillary artisan and reimplant the artisan anterior to the pupil. What do you think, Dr. Nihal? Do you agree about removal of the previous CTR?
I think it's very difficult.
It's very difficult.
Yeah.
So
difficult to remove the CTR itself. With the fibrotic capsular bag, you're going to cause a major damage. So I think the best situation in this case, if we are going to go for surgery and this eye is not amblyoptic, I would go and suture the whole capsular bag together with the CTR under a scleral flap to centralize the capsular bag and reposition the IOL. And this is the least manipulation to do.
So reposition the same artisan retropupillary?
Yes. I would go for this.
Okay, and would you trust the same iris again? This damaged iris, would you trust it again to fixate retropupillary artisan?
Retropupillary artisan, I don't know why he did implant a retropupillary artisan together with the CTR on this capsule, but I would go for the least manipulation. It's going to go for this surgery for a small corneal one, and you're going to go for a Prolene suture with a long needle to suture this CTR. And again, through small corneal wound, you're going to reposition the IOL and see what about the refraction. Is it okay? It is permissible to go for a good refraction and fit this baby or this child with spectacles, or if there's a wrong biometry or there is a myopic shift, I don't know. But I would start with the least surgery like this.
Yes, okay. So, Dr. Ayman, what is your, give me your last comment in this webinar. What would you do for this case?
Well, this is very difficult, and I think I would have to consult Dr. Nihal before putting on this case. But I would like, since we are already running out of time, I'd like to comment about the other eye. You mentioned that you didn't need to flip it. This means that the artisan was originally implanted wrongly.
Yes, it was a mismanaged case from the beginning.
This IOL has been dislocated.
Yes, we had the wrong IOL calculation, inversed and wrong way of implantation of the retropupillary artisan, and the right eye was not. He was not. We do not usually implant CTR in cases with progressive disease, connective tissue disease, that it will relocate. It will dislocate with time for sure, and the case was mismanaged. But I want to propose the other opinion that I would leave this case without management because it has just -2 and -2 astigmatism, and with a vision of 6/24, I would follow up with the patient a pet for a while before I decide to manage, and I will follow the refraction in the other eye. I just managed 1 minute before. At the end of our webinar, I'd like to thank Dr. Nihal for your time. And I'm very sorry for keeping you up late. I know you like to sleep early. And thanks, Dr. Iman. Thanks, Dr. Ayman. Thanks, Dr. Mahmoud. And thanks goes to Dr. Ken, who left early. And I thanks for all the audience, and I'm very sorry if I have no time to answer any of your questions. And I hope you find our webinar beneficial. Thanks you all, and see you in the next webinar. Thanks.
Thank you very much. Thank you, Dr. Nihal. Really, you appreciate your attendance. We always learn from you. I'd like to thank you very much. I'd like to thank that it's not easy for you, I know, to keep till this late time at night. Thank you very much. We always learn from you, your huge experience. Thank you, really thank you very much. I'd like to thank Dr. Ken, who just left and left a nice message for us, and a nice message for you, Dr. Heba, about your last surgical video. I would like to thank him, and again, I'd like to thank Dr. Mahmoud. And I want to again express one of the huge messages that we want to deliver to the audience from this webinar. Is the pre-operative assessment is extremely important, and now it's not a luxury to think in the genetic background of the cases of subluxated lens. It's one of the most important messages that we wanted to deliver. Thank you, Dr. Nihal, very much. Thank you, Dr. Heba.
Thank you. Bye.
Thank you. Thank you for the audience for keeping with us all this time, and we are sorry for not answering all the questions, but we tried as much as we could. Thank you. Bye-bye. Good night.